All right, so we're recording now. Knock on wood, we're recording at least. As we look at this process of cardiac conduction, a lot of students think that we first have to have the right atria contract, then the right ventricle, left atria, then the left ventricle. That's a common in that it's one atria, or basically one chamber at the heart contracting at a time. I want to spell this out so we're crystal clear. We have atria contract. It's not one chamber at a time. Now, when we look at the contraction of the left ventricle, when we have left ventricular systole, that's going to push blood out of the aorta to the systemic circuit, and it's going to increase our blood pressure. To measure blood pressure, we are going to use a device known as a sphygmomanometer. Sphygmomanometers are the devices, the technical name for the device that measures a blood pressure cuff. We use the units of millimeters of mercury because of how the initial barometers or pressure devices were designed. I personally, full disclosure, I think millimeters of mercury is a really old school, not effective way to measure pressure. I'm a much bigger fan of atmospheres for measuring pressures. We have 120 over 80 millimeters of mercury for our threshold between regular blood pressure and hypertension or high blood pressure. So let's talk about these pressure gradients. Knowing how blood flows through the heart is very important. We need to know the mechanisms at play. Recall from Tuesday, fluids, all fluids, whether it's a liquid fluid or will flow from an area of high pressure to an area of low pressure. This is a key concept. So as we look at our atria, while those atria are contracting, those atria have an increase in blood pressure. The ventricles relax while the atria are contracting, and they'll push blood past the atrioventricular valves, causing the ventricles to fill up with blood. After the fill up with blood, the atria will relax, and we have low pressure in the atria. If the atria have low pressure, there's a tendency for blood to flow backwards back into the atria from the ventricles. And as this occurs, the AV valves are snapped shut. The Purkinje fiber, not the Purkinje fibers, the chordae tendineae of the AV valves will be pulled taut and keep those AV valves from popping open and flipping backwards. During lab this week, you will have the option or the opportunity to go and actually feel actual chordae tendineae in a pig heart. Please take advantage of that opportunity. They're tough, they're fibrous, and super cool feeling. Now, as these ventricles are contracting, the AV valves are prevented from opening by the chordae tendineae. However, we have the aortic valve and the pulmonary valves, and those valves are in reverse. They allow blood to flow past them to the Now, when this is a term for the very first last semester, so it's been a while. I mean, it's been months since we had this term. Osculation is listening for a medical purpose. And we talked about how there's palpating, feeling for a medical purpose. We have osculating, listening for a medical purpose. And when we osculate, we typically are going to use a stethoscope and put that on different points on the patient's body to see what we will hear. And as we're listening to a patient's body, you can hear those valves opening and closing. Most people aren't able to hear the valves opening. We don't have hearing sensitive enough for that, but with a stethoscope, it's pretty easy to hear the valves snapping shut. And it's kind of like slamming a door in your house. Maybe you had a sibling that was angry at one point. They slammed their bedroom door shut, and in the house. Maybe even the neighbors outside with the door slamming shut. And when our valves in our heart are slammed shut, it makes a loud noise, loud enough that you can hear it. Those noises are the lub-dub. So when we think of the lub, the first noise, we call that sound number one, S sub 1. for the first noise. Then we have S sub 2 for the second noise, sub. Now, this is not rocket science. The harder you slam a door shut, the louder the noise it makes. We all understand that. And the same is true for the valves of our heart. The harder we snap the valve shut, the louder the noise it makes. So when we're looking at these valves in our heart, one valve, or one set of valves are closed with more force than the other set of valves. So let's back up for a moment here and look at these chambers of the heart. Hopefully this will make sense. As we look at the valves, we have the AV valves and we have the semilunar valves, the aortic and pulmonary semilunar valves. Slamming the AV valves close when the ventricles contract. And since the ventricles are very large, the ventricles have lots of myocardium, the contraction of the ventricles generates a lot of force and will slam the AV valves shut with a lot of force, making the lub, the loud noise associated with S1. So think S1, think AV valves slamming shut because the ventricles are squeezing really hard and generating a lot of force. Now, after those AV valves slam shut, blood will exit the ventricles through the semilunar valves, the pulmonary and the aortic valves. When the ventricles relax, we have the body's blood pressure. Most of us are going to be about 110/70. It's pretty normal for an adult. And that 110 millimeters of mercury and pushed backwards on the semilunar valves, causing them to slam shut. The pressure generated by our systemic blood pressure and pulmonary blood pressure is less than the pressure generated by the ventricles contracting, so the dub is not as loud. Now, if you're working with a patient that is young, super duper healthy, and you also have particularly good ears, every once in a while, there's a third noise that you can pick up. We don't really like to spend a lot of time fixating on this third noise because it's so hard to pick up with human ears. As the blood is gurgling in to the ventricles, it makes a whooshing noise, and we can occasionally hear the whooshing noise of the blood flowing past the AV valve. That's S3. One of the reasons why it's hard to hear over people in 30 is, first of all, they typically have more soft tissue over their chest, obscuring the sound. And then secondly, our valves lose some of their flexibility. So as we age, it's less of a flapping, gurgling noise that's made as the blood flows past our valves. So let's have a review question. Talk about on Tuesday of the conduction cycle in the heart. So as we're looking at this, where in the heart should we have more sodium leak channels if we want to increase the overall heart rate? Where would be the best spot in the heart to add more sodium leak channels? Once you figure out where you want that to be, touch that spot on the screen, or click on that spot on the screen. So, questions to ask yourself include, what structures are going to have lots of sodium leak channels? Another question to ask yourself is, what structure or structures regulate heart rate? If you figure out which of those structures has a lot of sodium leak channels, click that spot on the screen. Apparently the timer's not working right now. Let's say we have about 30-ish seconds left. All right, let's go 10 seconds. Hit something now. Make an answer right now so you can get some participation credit. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. All right. So guys, gals, the part of the heart that is governed by, for reaching threshold, it's the sinoatrial node. It's also the part of the heart that controls heart rate. So if we add more sodium leak channels to our sinoatrial node, we are going to have the sinoatrial node reach threshold faster, and we're going to have higher frequency of potentials. We're going to have a higher heart rate. This question was a little bit more difficult. There's really two concepts in one. Let's see how we did. I'd say for the most part, the SA node got a lot of love there, and then the AV node to a lesser degree. Let's move on. Let's talk about the conduction cycle and phases of our cardiac conduction cycle. As our heart is contracting and relaxing, there's going to be some key stages we need to talk about. Stage number one, and this is a cycle, so we have to arbitrary starting point. Stage one is filling the ventricles with blood. This is called ventricular filling. To fill ventricles, the ventricles need to have low pressure. Ventricles will have low pressure when they're relaxing, so this occurs during ventricular dystole, not ventricular systole. So during ventricular dystole, when ventricles are relaxed, they fill with blood. For blood to rush into the ventricles, we're going to have the blood go past the AV valves. The AV valves will open, high pressure in the atria pushes blood into the ventricles. And ventricular filling is going to correspond to the blue and green bars on this Wiggins graph. And this Wiggins graph, I could probably spend an hour talking about just this figure right here, but we don't have that kind of time, so we're going to try to give you the highlights. Occurs at this stage, and then during this ventricular filling process, we have a phenomenon known as end diastolic volume. End diastolic volume is the intuitive term. It applies to the left ventricle, is what we really care about here. It's the volume of blood in the left ventricle at the end of dystole. It's the end diastolic volume. For a typical human heart, end diastolic volume is about 130-ish milliliters of blood. You know, and there's variations here. Are you healthy? Are you not healthy? Are you a large individual? Are you a small individual? There's lots of variation with that number. Next, we're going to have isovolumetric contraction. And when we look at this phase of volumetric contraction, we increase pressure without a change in volume. And the isovolumetric contraction phase lasts for just a fraction of a second. The ventricles are just starting to contract. And as those ventricles just start to contract, there's a short period in time where they don't change in volume. Hence the name isovolumetric contraction. Because this is going to be a contraction, it has to happen during systole. And as we look at that isovolumetric contraction, before the ventricles can push any blood out, they have to first close the AV valves, open the semilunar valves. And as they slam those AV valves shut, we're going to have the lub. So as we look at this graph, isovolumetric contraction is corresponding to that phase. The first of our cardiac sounds corresponds to isovolumetric contractions. We then have ventricular ejection. We're going to take blood and push it out of the ventricles into the pulmonary artery and into the aorta. And there's some things that can change during this process. We can have our stroke volume be altered from individual to individual. And some things that influence the amount of blood out of the ventricle include the strength of contraction. If we squeeze really hard versus not squeezing hard, that'll change how much blood we squeeze out or push out of the ventricles. Something else that can influence how much blood is pushed out of the ventricles, or something else that influences the stroke volume during ventricular systole, is going to be the end diastolic volume. If you have more blood at the beginning, the ability to push more blood out of the ventricle. So when we look at EKGs, you'll see a patient with an abnormality that makes it difficult for them to relax their ventricles. If they have problems relaxing their ventricles, They can't put blood in their ventricles, fill their ventricles. If we don't put blood in the ventricle, it's hard to squeeze blood out of the ventricle. Now, when we look at ejection fraction, this is an important fraction. It's a good indicator of overall health. Generally speaking, when blood gets into the ventricle, you want to pump the blood out of the ventricle. And if you pump out more blood, you can have more blood circulating in your body. So as we look at the ejection fraction is a measurement of how much of the blood gets moved out of the ventricle. For a typical adult, we're looking at about 50-ish% of the end diastolic volume. So we'll just use easy numbers. If we say the end diastolic volume is 100 milliliters, we can pump about 50 of those milliliters out with a single contraction-ish. And of course, there's always going to be a spectrum depending on individual health and individual circumstances. To calculate our ejection fraction, we need the end systolic volume. And to find out the end systolic volume, or to find out how much blood is left over in the ventricle after it squeezes blood out, end systolic volume, we first need to know end diastolic volume, how much blood did we start with, and then how much blood did we move out. If you take how much blood you start with, subtract how much you pumped out, the leftovers is called the end systolic volume. And you use end systolic volume and diastolic volume to calculate your ejection fractions. We also are going to have isovolumetric relaxation. During this phase, the ventricles relax and have low pressure. This is the very beginning of ventricular dystole. And as these ventricles are relaxing, the aortic valve and the pulmonary valve are going to snap shut. This corresponds to S2, the dub, the quieter of the two noises. Now, when we look at a typical person at physical rest, assuming they aren't really scared or agitated, so we'll just assume most of the people in this room right now, atrial systole lasts for about 1/10 of a second. So our atria spend 1/10 of 1 second, or 100 milliseconds, squeezing blood out into the ventricles. Because the ventricles are larger, it takes a longer period of time to the ventricles. So ventricular systole is going to last for about 300 milliseconds, or 3/10 of a second. And then there's a period of time where we reset. At this period of time where the heart is resting is known as the quiescent period. And it's important to have a quiescent period, or a resting phase, because we need to recharge our cardiomyocytes. Our heart needs to be able to beat our entire lifespan. And if we didn't have these little recharge periods in between heartbeats, our heart would fatigue much more rapidly. When we add up all of these numbers, a typical cardiac cycle is about 8/10 of a second. If you take 60 divided by 0.8, you end up with about 75-ish beats per minute when a typical adult is at rest. Now, I need to really highlight this. Left and right ventricles eject the same amount of blood. This is a key concept. When the left versus right ventricular ejection is altered or different, that's when a lot of disease states or homeostatic imbalances can set in. If we have a difference in blood ejection between the two sides of the system, we can overpressurize one system and underpressurize the other side of the system. So when we look at these sides, we're thinking the pulmonary side versus the systemic side. These differences in pressure states between, or overpressurizing or depressurizing one circulation circuit versus the other, puts stress on the heart and can lead to congestive heart failure. During this process of congestive heart failure, there's some secondary symptoms or causes. They can include a heart attack, a myocardial infarction. They can include consistently high blood pressure or chronic hypertension. We all have hypertension every now and then, you know, when you get stressed out or maybe you're climbing the stairs in the Phillips Science Building. Temporary hypertension is normal, it's healthy. consistently elevated pressure is not a good thing for us. We can have a valvar insufficiency. That's a nice way of saying that the valves allow blood to flow backwards. And that can cause that congenital heart failure, excuse me, congestive heart failure. And then finally, we can have a congenital defect. So there can be some birth defect. When we think congenital, I want you to think associated with development in utero, a birth defect. A very common congenital heart defect is within the interatrial septum, that wall of tissue that separates the left and right atria. A common congenital defect is that the foramen ovale doesn't close to become the fossa ovale, or the ovala fossae, depending on which textbook you're looking at. In other words, it's not uncommon for adults to have blood flow directly from the left atrium into the right atrium, or vice versa, or having oxygenated and deoxygenated blood mix before they get into the ventricles. If this happens, it's not really the end of the world. I can't help but think of a former coworker of mine, Claire Ruckheim. She has this congenital birth defect, and she runs marathons, several a year. So it's not the end of the world to have that particular one, but it is pretty common. Let's talk about ventricular output. If we have more blood being pumped into the lungs, or the pulmonary circuit, compared to the systemic circuit, we are going to have too much pressure in the pulmonary circuit. Overpressurization of the pulmonary circuit is going to cause excessive blood plasma leakage into the lungs, and this is going to be associated with the lungs filling up with fluid. And individuals that have this occur are going to suffer from low blood oxygenation rates. If your lungs are full of fluid, it's hard to put air in them. In extreme cases, they can drown in their own fluids. This is what killed my grandpa Eddie. He had excessive blood flow into his pulmonary circuit as opposed to his systemic circuit, and he died a couple days after a farming accident due to this issue. When we look at the other end of the spectrum, if we have excessive blood flow into the systemic circuit, that's going to cause excessive blood pressure in the stomach circuit. We'll have blood plasma leaking out into the extracellular space. And oftentimes, we'll have edema or swelling of the tissues in or associated with the systemic circuit. So if somebody is carrying excess fluid, and this is a chronic issue, this inadequate pumping between the left and right ventricles may be the cause. Usually, we're looking at a lymphatic issue, though, for most edemas, not necessarily a ventricular ejection imbalance. When we look at cardiac output, this is the amount of blood that leaves the left ventricle in 1 minute. And it's a super easy calculation. I'm going to ask you to memorize this equation. I will expect you to be able to calculate cardiac output if I give you the heart rate and the stroke volume. If you know how much blood leaves the heart per beat, and you know how many beats per minute there are, it's a simple multiplication question. And if you have a test question on this, it's going to have very easy numbers. I'm not going to ask for something like 97 beats per minute multiplied by 14.3 milliliters per stroke. That's stupid. I don't want you to have to use a calculator. It'll be nice, easy math like 10 milliliters per stroke and 100 beats per minute. Nice, happy math like that you can easily do in your head. So for a typical human or typical adult, we're looking at a cardiac output of 4 to 6 liters, or 1 to 1.5 gallons of blood per minute when we're resting. As we increase our activity, cardiac output will go up. As high as 35 liters per minute for world-class athletes, but for a typical healthy person, we're looking at about 21 liters per minute. Or, to put it in more of an American unit, we're looking at about 5 gallons of blood per minute. The cardiac reserve is the difference between your resting cardiac output and your maximum cardiac output. Individuals that have a high cardiac reserve can go from rest to doing very strenuous physical activity because they have the ability to upregulate their cardiac output a lot. People with low cardiac reserves, generally speaking, can't do rigorous activity. They don't have the ability to increase their cardiac output that much, and consequently can't keep up with the rigorous physical activity. When we look at cardiac outputs, you right now can influence your cardiac output just by exercise. The more you exercise, the more your cardiac output will go up. Another factor that strongly influences cardiac output is age. As we age, cardiac output goes down, which is a key reason why we have age divisions for a lot of life activities like running 5Ks or half marathons, stuff of that nature. Having a 20-year-old compete against an 80-year-old isn't necessarily the fairest thing. When we look at our heart rate will correspond directly to the pulse. A lot of individuals will take pulse and heart rate and use them as synonyms with each other, but there is a distinction between pulse and heart rate. Heart rate is the contraction of the chambers of the heart. A pulse is a surge in blood pressure in the systemic circuit. Now, thankfully, they correspond really well to each other. When the heart contracts, blood pressure surges. So mathematically, using them as synonyms with each other is one surge of blood pressure. So heart rate and pulse are usually going to be the same number. But we need to be a little pedantic here, because occasionally, when you're measuring pulse, you don't feel the surge in blood pressure that corresponds to a contraction of the heart. You may have noticed this yourself. Maybe you're in class, you're bored, and you're just measuring your pulse to see what happens. And you notice, I think I skipped a beat there. We don't always feel the surge in blood pressure when we're measuring our pulse. When we're really young, heart rate is quite elevated. In utero, when we do fetal ultrasounds, it's not uncommon to have a fetal heart rate of 150 beats per minute at rest. And one of the phenomena we notice is that as we're looking at mammals, and we as humans are mammals, the bigger the mammal, the slower the resting heart rate is typically going to be. Mice have sky-high heart rates. Elephants have really low heart rates. And we as adult humans, as we age and get a little larger, our heart rate's going to drop down and be lowered. As we get quite old, when we reach the geriatric stage, we have an elevation in heart rate, and that's going to be associated with some disease states setting in. Here's an interesting bit of trivia. Whether you're looking at a small organism or a large organism, there's about the same number of lifetime beats in the heart. So mice don't live that long, but they have a really high heart rate. Elephants live for a very long time and have a low heart rate, and there's a correlation between your lifetime and the number of contractions of your heart. If our heart rate is elevated above baseline, for an adult that's typically 75 beats per minute, that's known as tachycardia. In terms of having a number associated with it, because we have a variation, we say arbitrarily over 100 beats per minute is going to be tachycardia. When we look at our baseline of 75 beats per minute, if we're significantly below that baseline, at 60 beats per minute, we'll have a slow heart rate. We have brachycardia or bradycardia. And these heart rates can be influenced by the ions we expose our heart to. The heart rate can be influenced by a choranotropic agent. And we can have two different kinds of choranotropic agents. We can have our positive choranotropics or our negative choranotropics. Positives will raise the heart rate, negatives will lower our heart rate. Now, when we look at our nervous system that regulates our heart rate, the part of our nervous system or branch of our nervous system responsible is the autonomic nervous system. We aren't consciously choosing when to contract our heart. It just happens automatically. Some individuals are able to meditate, and by relaxing through that meditation, they can lower their heart rate by upregulating their parasympathetic nervous system. But for the most part, it just is completely involuntary. Within our brain, within the brain stem, particularly the medulla oblongata of our brain stem, there is the cardiac conduction centers that initiate our heart rate. And we have a stimulatory effect from the sympathetic pathway. When we think of the sympathetic nervous system, that's the fight or flight branch of the autonomic nervous system, it's going to be great for lots of activity. Sympathetic activation is going to raise the heart rate. And when we look at the other branch of the autonomic nervous system, the parasympathetic branch, that helps us to rest and digest, will relax and our heart rate goes down. The primary nerve of the parasympathetic pathway to our heart is the vagus nerve. So let's first look at the sympathetic pathway. Our sympathetic pathway of the heart is going to be associated with some androgenic fibers. When we say androgenic, we mean that these fibers are going to activate receptors associated with hormones from the adrenal gland. In particular, we have epinephrine and norepinephrine, also known as adrenaline and noradrenaline, hence the namesake of androgenic. Androgenic receptors have been first isolated when they were noticed to respond to adrenaline, their namesake. There are multiple kinds or variations of these receptors. We have alpha androgenic, beta androgenic. We even have some gamma androgenic receptors. We're not going to focus on the different kinds of androgenic receptors and active site inhibition versus allosteric inhibition. This is not a biochemistry class. So we're just going to focus on the most significant one for the heart, which is the beta androgenic fibers of the heart. These are the androgenic receptors in the heart that are going to respond to adrenaline and noradrenaline and cause an elevation in heart rate. Here's a really good margin note. When a patient takes a beta blocker, which is a very common category of drugs, beta blockers are going to block the beta androgenic receptors and make it hard for that patient to raise their heart rate when they're stressed out. A beta blocker will block the signal from the sympathetic pathway to a patient's heart. Consequently, those beta blockers lower overall heart rate and lower overall blood pressure. Beta blockers are a common hypertension medication. Now, let's say we have either adrenaline or noradrenaline bind to the beta androgenic receptor on the heart. Binding to that beta androgenic receptor is going to trigger secondary signals inside of the heart. Adrenaline and noradrenaline have a difficult time traveling across the cell membrane. So as they bind to that surface receptor, and this is, think back to last semester, this is one of the G-coupled protein cascades. We're going to have adenylyl cyclase activated. That turns ATP into cyclic AMP. And that cyclic AMP then amplify the signal inside of the heart. As a secondary messenger inside of the cardiomyocyte, cyclic AMP will cause the signal to be multiplied and amplified. One adrenaline molecule can have a very profound effect on a cardiomyocyte because of its amplification process. This is one of the reasons why just a little tiny bit of adrenaline can cause such a significant change in your cardiac output. When these cyclic AMP molecules are released in the sarcoplasm of the cardiomyocyte, it's going to cause more calcium channels to open within the plasma membrane. This is an influx of calcium into the sarcoplasm. Think back to last semester. When we looked at the contraction of muscle tissue that's striated, like cardiomyocyte, like skeletal muscle tissue, calcium in the sarcoplasm can trigger contractions. So as we add more calcium to the heart, we are more likely to initiate the cross-bridge cycle and have contraction of that striation, or the sarcomere, to be more precise. Additionally, more calcium ions are going to change the membrane voltage. As we add more positive calcium ions into the cardiomyocyte, that raises the voltage. Calcium ions are positive. More calcium ions mean more positive charges. And we get closer to threshold, and we're more likely to depolarize those cells of the heart. Not only the cardiomyocytes, but the neuronal cells of the sinoatrial node. We also find that we are going to have an overall increase in contraction strength and overall increase in heart rate. So we increase both at the same time. Heart rate is going to primarily increase as the SA node gets closer to threshold. Contraction strength increases primarily because the cardiac myocytes have more calcium being exposed to the sarcomeres within their sarcoplasm. Now, the theoretical maximum we can raise our heart rate to is about 230 beats per minute. Sometimes when you do the math, you get 220 beats per minute. You should never see somebody with a heart rate over 230 beats per minute. Typically see this in a teenager that's super duper healthy, but as we age, this maximum is going to be reduced significantly. The problem with excessively high heart rates is we don't have enough time for ventricular filling. We don't have enough time for blood to fill the ventricles. If we can't put blood in the ventricle, we can't squeeze blood out of the ventricles. So at a certain point of time, we have a diminishing return for cardiac output. Elevating heart rate causes cardiac output to go up, but if we elevate our heart rate too much, cardiac output starts down again. So we have some feedback mechanisms in our body that will lower our heart rate a little bit, so we have time to fill the ventricles with blood. And what we typically find is that for a typical healthy adult, we have a theoretical maximum of less than 180 beats per minute. And when we think of a typical healthy adult, I want you to think 30 plus years of age. Let's talk about how the parasympathetic nervous system affects heart rate. Our parasympathetic branch of the autonomic nervous system is the rest and digest branch. It helps us to relax. It's going to inhibit cardiac output. If we're resting, we don't want our heart to be depolarizing and repolarizing. We want the cardiac cycle to be reduced and slowed down. So what we find is that the parasympathetic nervous system is going to counteract the sympathetic nervous system. The action of the vagus nerve will slow down and lower the heart rate. The vagus nerve is activated at the synapses, at the axon terminals of the vagus nerve. The neurotransmitter acetylcholine will be released. Acetylcholine is associated with the parasympathetic nervous system. Acetylcholine is going to be released from the vagus nerve. And what we find is that when we take acetylcholine and expose it to the heart, it is going to lower the heart rate. Those cholinergic receptors that respond to acetylcholine are going to decrease heart rate when they are activated. There's a special name for those receptors. There are different kinds of cholinergic receptors. One of the kinds that we're going to focus on is the muscarinic receptors. And this is just random trivia for you. This particular receptor is named after a species of mushroom isolated from. And as more research has been done, it's been found that acetylcholine binds to the same chemical that was isolated from that species of mushroom. Now we typically just refer to them as cholinergic receptors. When we take this acetylcholine and cause it to bind to those cholinergic or the muscarinic receptors, we're going to open potassium gates or potassium voltage gated channels. And as just potassium ligand gated channels. And as we open those potassium gates, potassium ions rush out. The loss of potassium ions from the intracellular fluid lowers the voltage farther away from threshold. And if we reduce the voltage and lower it away from threshold voltage, it is more difficult to initiate the action potential. It takes a longer period of time to initiate that action potential. I'll say that again, because this is a very key concept. The loss of potassium from the intracellular environment is going to lower the voltage intracellularly and make the voltage go farther away from threshold, overall lowering the heart rate. We will have a reduced frequency of action potentials. let's talk about vagal tone. Our vagus nerve is going to be constantly releasing acetylcholine, constantly down-regulating our heart rate. Without the vagus nerve down-regulating our heart rate, without the vagus nerve to counteract the sympathetic nervous system, our heart rate typically is going to be elevated. We don't have anything to counteract the stimulatory effect of the sympathetic branch of our nervous system, and we typically have patients have a heart rate of about 100 beats per minute. Our vagus nerves effect, that acetylcholine that's continually released from the vagus nerve, will typically hold our heart rate down to the 70s, between 70 and 80 beats per minute. Now, if we look within the medulla oblongata of our brain center or brain stem, we have a lot of receptors in there. We have chemoreceptors, we have nocioreceptors, we have propio receptors, we have Baro receptors. There's a whole bunch of different sensory structures that we talked about within the nervous system. We're going to focus on, in particular, propioreceptors right now. Because it's been a while, let's review. A propioreceptor senses the movement of our body. And if we move our body, we activate those propioreceptors. And it's been found that just moving our body, just activating propioreceptors, elevates heart rate. There's even some research that shows that just thinking about moving your body can elevate your heart rate. Just a little bit. It's better to do it yourself as opposed to watch other people. Now, we increase cardiac output before we have any homeostasis occur because we want to be. If we start moving our body, if we just start exercising, it takes a while for our blood chemistry to get altered, and we help to maintain homeostasis by increasing cardiac output right away. We also have baroreceptors. And when we think of a baroreceptor, I want you to think of, well, the word right there is baro, meaning pressure. A barometer is something that measures air pressure. In our body, a baroreceptor measures blood pressure. So we have baroreceptors in our body. In particular, we have baroreceptors in the aorta. We're also going to have baroreceptors within the carotid artery that supplies blood to our brain. And these baroreceptors are going to measure the pressure of the blood as it's leaving our bodies. You probably noticed when you're lying horizontally on the couch for a while and you stand up quickly, a lot of times it's pretty common to feel, whoa, you feel kind of dizzy. And the reason for that is the baroreceptors in your body haven't caught up to the change in blood pressure. So when you're blood pressure to the brain drops dramatically, the baroreceptors pick up that signal, and then you compensate by raising your blood pressure so you have enough blood flow going to your brains. In response to excessive pressure, or hypertension, baroreceptors signal that and try to lower cardiac output so that we lower the blood pressure. In response to excessively low blood pressure or hypotension, baroreceptors set up and elevate cardiac output to hopefully elevate blood pressure. There are other mechanisms at play. The urinary system also helps to compensate for blood fluctuations, and the smooth muscle in our blood vessels also helps to compensate. But we're focusing on the heart right now. So in response to low blood pressure, the heart pumps out more blood. In response to high blood pressure, the heart pumps out less blood. We also have chemoreceptors. These chemoreceptors measure the chemicals in our blood. And we talked a lot about the blood-brain barrier last semester. And that blood-brain barrier prevents most of the brain from accessing the blood directly. But there's a few parts in our body, particularly in the brainstem, where the dendrites or axons of a neuron will be on the blood side of the blood-brain barrier, so they can sample blood chemistry. Specific chemicals we're really interested in include carbon dioxide concentrations, the hydrogen ion or pH of the blood. We're pretty interested in the oxygen gas concentration. And we're also going to be interested in some other chemicals as well. But blood pH, carbon dioxide as a gas, and then oxygen as a gas are the three biggies. Of those three, when we look at cardiac output, carbon dioxide is the most important. If we have more carbon dioxide, that carbon dioxide will acidify our blood. It turns into carbonic acid in our bloodstream. Think back to last week. Our red blood cells have an enzyme called carbonic anhydrase. That carbonic anhydrase in our red blood cells will take carbon dioxide in the blood and turn it into carbonic acid, and then we can move the carbon through our blood as a bicarbonate ion. More carbon dioxide in our blood results in more hydrogen ions and a decrease in the pH. Our pH becomes more acidic and will drop down below the 7.35 baseline. If we have excessive carbon dioxide, we can have hypercapnia, which refers to too much carbon dioxide. Too much carbon dioxide causes there to be too much acid, which is called acidosis. One leads to the other, but they are two separately distinct things. And it's possible, but very unlikely, that you could have acidosis without hypercapnia or vice versa. Low blood oxygen is known as hypoxemia, and that's typically going to slow down our heart. If we slow, and let's pause for a moment and think about this. We want to slow down cardiac output in response to low blood oxygen so that the blood can spend more time in the lungs. And if the blood spends more time flowing through our lungs, it has more time to oxygenate hemoglobin molecules within the erythrocytes. And we're able to dump more oxygen into the blood and thereby raise our blood oxygen levels. As we look at these baroreceptors and these chemoreceptors, we have negative feedback loops. A negative feedback loop will help us maintain a set baseline. These are not a positive feedback loop like that blood clotting cascade we talked about, either the intrinsic or extrinsic cascades we talked about last week. We also have chemicals that can affect our heart rate. Our autonomic neurotransmitters, adrenaline and noradrenaline, or epinephrine and norepinephrine, can influence heart rate. We have norepinephrine. For those of you who are curious, norepinephrine is right up here. Acetylcholine is pictured right there. So the norepinephrine or noradrenaline rate elevates the heart rate. Acetylcholine lowers heart rate. We also find that noradrenaline and epinephrine, and here's epinephrine right here, also known as adrenaline, are going to stimulate cardiac output. And there's some other chemicals that can stimulate cardiac output. We can have nicotine. It's been well established that when somebody is consuming nicotine, heart rate goes up. A lot of people need to smoke their cigarette, vape their Juul, or whatever to help wake up in the morning. Another thing that can help raise or elevate heart rate is thyroid hormone. Thyroid hormone is typically going to be a mixture or a combination of T3 and T4 combined. Of those two, the most important one is going to be thyroxine, which is pictured right here. In case you're curious, nicotine is this molecular structure. And then finally, my personal favorite, caffeine. Caffeine is a mild stimulant that is going to inhibit the breakdown of cyclic AMP in the body. And if the cyclic AMP, that secondary messenger, hangs around longer, it can stimulate the opening of calcium channels for a longer period of time, so we get more effect. Another way to think of caffeine is caffeine makes the androgenic receptors or the androgenic signals more effective. There's a synergenic effect. One adrenaline molecule will cause more stimulation in the presence of caffeine because the cyclic AMP generated by that adrenaline molecule will hang around for a longer period of time in the cytoplasm. Electrolytes can also influence our heart rate. Potassium is a potent electrolyte that can influence our heart rate, and it has a very, very big effect on our heart rate. This effect of potassium on our heart rate has led to it being incorporated in a lot of murders. Potassium hydroxide, potassium cyanate. We could have potassium nitride. Various forms of ionic potassium have been injected into the victim's blood in 1 million murder mystery models, including, for those of you who like murder, Agatha Christie Poirot with Hercule Poirot. Excellent murder mysteries if you're ever interested in watching some of that stuff. Too much potassium in our bloodstream is known as hyperkalemia. Hyperkalemia is going to cause too much calcium going into the cardiomyocytes, and that makes the myocardium less excitable. We want that myocardium to initiate and hit threshold. And if that myocardium is less excitable, it's more difficult to reach threshold. It's more difficult to contract the cardiomyocytes. And the theory behind this, or the physiological theory behind this, is there's a lot of potassium leak channels in our body. If there's too much blood potassium, the potassium leaks into the cell and then hyperpolarizes that cell and makes it more difficult to depolarize. And then the patient can't contract their heart, or the victim in the murder mystery will die. And then because of all the leak channels, the potassium will diffuse evenly throughout the body, making it very difficult to detect the abnormally high potassium levels. With hypokalemia, we don't have enough blood calcium, and the cells are not going to have enough of the potassium in it, and it's going to be difficult to stimulate them as well. We have to have an increased stimulation as well. Either way, too much or too little potassium has a very profound effect on our bodies. Calcium is less potent than potassium. Too much calcium is hypercalcemia. It decreases heart rate. Too little calcium is hypocalcemia and increases heart rate. Let's have a review question. Apparently the timers just aren't working today. If a patient has a heart rate of 90 beats per minute and a stroke volume of 50 milliliters per beat, the cardiac output would be what? Don't forget the units in your answers. I like the correct units. In particular, I want milliliters for my units. Milliliters per minute. So ask yourself how to calculate cardiac output. Cardiac output is calculated by measuring stroke volume, heart rate. Our stroke volume is 50 milliliters per beat. Our heart rate is 90 beats per minute. What is 50 multiplied by 90? Or for those of you who are good with mental math, 5 times 9 is 45. Add 2 and 45. I see a lot of people using calculators right now. Ten seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1. Beautiful. 4,500 milliliters per minute. I also would have accepted milliliters space PER space minute as well. Mathematically, when you see that division sign or in the fraction, it means per. So yeah, 4,500 mils per minute. Fabulous. Well done, class. Looks like a couple of us got a little click happy with our minutes. Let's look at stroke volume, guys, gals. When we look at stroke volume, some things that will influence our stroke volume include how much blood gets into the heart, into the left ventricle before it contracts, so end diastolic volume, aka the preloading. You can have how hard the ventricle can squeeze the blood, contractility, and we could have afterload, how much blood is left over after contraction, also known as the end systole, dystole, end diastolic volume, end systolic volume. How much blood is left over after contracting it, after systole. So let's talk about preload in more detail. Preload can be influenced by a variety of different things. The tension in the myocardium of the ventricles is particularly the most important factor. If we have increased preload, that's going to cause the ventricle to stretch out more. And as that ventricle is stretched out more, that increases the tension on the ventricle, and it's going to cause the ventricle to squeeze harder. If we put too much blood in the ventricle compensates by squeezing harder and pumping out more blood to get back towards that homeostatic pressure that it's used to having. Now, if we're exercising, we're going to activate our skeletal muscles. That's going to cause more blood to get back to the heart, that it will increase venous return and cause the myocardium to stretch out even more. So just moving your bodies, just exercising will also cause preload to be influenced. It will cause preload to go up and a stretching of the myocardium. What we typically find is that if we put more blood in the ventricle compensates by squeezing harder to get rid of the extra blood you put into it. And then conversely, if you don't put enough blood in the ventricle, the preload is too low, the ventricle can compensate by not squeezing as hard. What we find in this phenomenon is known as the Frankstarling Law, is that as you stretch cardiomyocytes, you increase the rate of contraction of those cardiomyocytes. Overall, stroke volume, the amount of blood coming out of the heart, it will be proportional to our end diastolic volume, the amount of blood that we put into the ventricle before we contract. For those of you who may not be mathematically inclined, this symbol right here means proportional in math. That's an abbreviation for proportional to. So if we have more blood go into the ventricle, more blood will exit the ventricle because that ventricle has been stretched out more. Less blood in the ventricle causes less blood to exit the ventricle because the cardiomyocytes are not as stretched out. And this contraction of the cardiomyocytes, the contractility, is known as inert ropey. And we can have a positive or a negative inotropic agent. For your lab assignments this week in PhysioX, you looked at some chemicals that influenced inert ropey. In particular, digitalis is a commonly described inotropic medication. Digitalis was initially isolated from the genus Digitalis, hence its namesake. The common name is foxglove. So actually, this is actually pretty cool. Pharmacists were looking at individuals that were practicing folk medicine, and in folk medicine, taking foxglove and harvesting it and brewing a tea and drinking foxglove tea was found to influence blood pressure. And some biochemists and pharmacists looked at the mechanisms behind it, isolated this molecule, purified it, now they synthesize it, and they sell it as the medication Digitalis, which is a blood pressure medication. Now, when we look at these agents, positive inotropic agents are going to increase contractility strength. They're going to increase stroke volume. So hypercalcemia, too many calcium ions, causes there to be more contraction strength. Having an increase in our catecholamines, And I believe I made a mistake right here. This should be an increase in adrenal hormone levels, not calcium levels. I apologize for that. Adrenal hormones are the catecholamines. So I'm going to put an AH for adrenal gland hormones. Think epinephrine, norepinephrine. If we have excessive complex carbs or excessive digitalis, that can all cause contractive strength to go up. When we look at negative inotropic agents, these are going to be things that are going to decrease contractility strength. So too little calcium, too little potassium, or activation of the vagus nerve, aka the addition of acetylcholine, will reduce contractility strength. Let's talk afterload. Afterload is the amount of blood left over after we're done squeezing the blood out. Afterload corresponds directly to end systolic volume. They are synonyms with each other for all intents and purposes. Now, when we're looking at afterload, one of the biggest factors that influences afterload is how hard it is to push the blood out. If it's really easy to push the blood out, you can push more out. If it's hard to push the blood out, well, you don't push as much blood out. And this ability to push the blood out of our ventricle corresponds to blood pressure, systemic blood pressure. If you have really high blood pressure pushing blood back into the ventricle will eventually trying to push the blood out to the aorta. So individuals with high blood pressure typically have a larger afterload. Individuals with low blood pressure typically have a smaller afterload. They're able to push more blood out. Another thing that can influence afterload is not just blood pressure, but physical blockages. Physical blockages will impede circulation. So when we look at our lungs, if we have some kind of a pulmonary disease that makes it difficult to move blood through the lungs, maybe that could be a pulmonary embolism, something very transitory and short term, or maybe it's something more long term like plaques or cholesterol building up in the blood vessels. That is going to reduce circulation. A generic umbrella term, so this is a broad term, is cor pulmonale. And cor pulmonale is a broad term that refers to all lung disease that restricts output of the right ventricle. And if we have these lung diseases like emphysema, bronchitis, black lung disease, and almost nobody gets black lung disease anymore. So black lung, for those of you who are wondering, black lung disease used to be very common in coal miners. If you spend a couple years breathing in coal dust, you have coal buildup in your lungs and you get black lung disease. The closest thing to that now is probably chain smoking cigarettes. But if you have that obstruction in the lungs, the right ventricle has to squeeze harder, and then the myocardium of the right ventricle is thickened, and as the myocardium of the right ventricle thickens inappropriately, we can't put as much blood into the right ventricle. Now, if we're going to exercise, this is not rocket science. The harder we exercise, the harder our heart pumps, the more blood that leaves our heart. How are we doing? We have 7 minutes left. I mentioned we have Propio receptors that measure the movement of our bodies. Propio receptors will increase cardiac output. We're also going to find that we have an increase in cardiac output from the sympathetic branch of our autonomic nervous system. This is all review. And as we're looking at this physical activity, we're also going to find that there's an increase in muscular activity that causes the veins to get squeezed more, and more blood will be pushed back to the heart. More blood entering the heart will cause more blood to exit the heart, because the left ventricle output and right ventricle output need to remain equal to avoid those edema-based diseases. Now, if you exercise a lot, your heart's going to be pumping hard a lot of the time. And it's just like lifting weights. The more resistance training you give a muscle, the more developed, the more hypertrophy of that muscle will occur. So what we find is that people who exercise a lot will have some mild ventricular hypertrophy. This ventricular hypertrophy is associated with the exercise and the strain of the exercise. It's not associated with chronic high blood pressure. So this is a good kind of ventricular hypertrophy. Individuals that have chronic hypertension have the bad hypertrophy of their ventricles because those ventricles are always having to work hard as opposed to getting a break in between. When we look at coronary artery disease, this is a big, broad umbrella term. This broad umbrella term includes any homeostatic imbalance of the arteries of the heart. Another way of saying this is anything that can go wrong with the blood vessels of the heart is called a coronary artery disease. So it's a pretty broad term. This could result, we'll talk about some common coronary artery diseases, one of which is going to be atherosclerosis. And when we look at atherosclerosis, that's a potato, athero versus atherosclerosis, we're going to have lipids building up inside of the atrial wall. And it's not just on the inner lining. It's not in the lumen of the artery. It's actually going to be nestled directly under that super slippery layer that lines the artery, the tunica intima. And directly underneath the tunica intima, we'll have these lipids build up. Things that are associated with this can include high blood pressure, can include diabetes, or can include anything else that could stress or damage the tunica intima. Once we have an injury to the tunica intima, or the inner lining of our blood vessels, that allows lipids to get tucked underneath and start to build up. As those lipids build up, they start to bulge and grow, and eventually they recruit calcium ions. And the recruitment of those calcium ions and some transformation from some of the leukocytes, particularly macrophages, will take these lipids and turn it into this kind of hard, solid mass of what is known as foam cells, or an atherosclerotic plaque, also known as an atheroma. And these atheromas, make that go away, are going to attract platelets because of blood flow irregularity, particularly on the side or the downstream side of the plaque. There's going to be extra turbulence and extra low blood pressure, and that extra turbulence associated with the low blood pressure immediately downstream of the bulge can stimulate clotting of the intrinsic pathway. This bulging mass is also going to just physically block the opening, block the lumen of our blood vessel. This reduction in blood pressure can cause pain in the chest. This is called angina pectoralis. We typically are going to have angina pectoralis occur if a coronary artery is 3/4 blocked blood flow. This angina pectoralis can manifest in the center of the chest, on the left pectoral muscle, or radiating down the left arm. As we look at this atheroma or plaque, it may swell to the point of rupturing. As it ruptures, we'll have the plaque start to travel, and will typically get lodged in a smaller blood vessel. This is going to block the blood flow. This is known as, in the heart, a heart attack or myocardial infarction. We also are going to find that as inflammation continues, it becomes hardened, and it becomes an arteriosclerosis. And this is the term most people think of. The arteriosclerosis is the hardened plaque. It's not the same thing as an atherosclerosis. It's an arteriosclerosis. sclerosis. And unfortunately, they sound very similar to each other. An arteriosclerosis can be thought of as a hardened atherosclerosis, causing that blood vessel in general to be hardened. Coronary artery disease is associated with an excessive amount of low-density lipoprotein, or LDLs, the bad cholesterol, for those of you who've taken a nutrition class. As we have excessive LDL concentrations in our blood, those LDLs are going to bind to receptors in the tunic intima, or the lining of our blood vessels, to trigger inflammation. Some things that are associated with coronary artery disease include your genes. When we look at ethnic foods, individuals that have a lot of fatty food in their ethnicity, think Germans, for example, don't have as many alleles associated with coronary artery disease. Individuals that don't have a lot of fatty foods in their cultural heritage have more alleles or genes associated with coronary artery disease. And we're done with class for the day. We'll pick up on this slide on Tuesday.